Think about the triple aim. You want to provide high quality care that's accessible and affordable. And so when you think about the therapies, PT and the other therapies, I'll lump them all together. They are one, they help multiple populations, whether it be post-recovery, strengthening, the athlete that wants to do that, whatever it is, right? It's the healthy and folks that are also have some kind of injury or ailment. Number two, it's really not, it's super empowering. It's both physical and mental in regards to helping people really, get back to their goals, whatever those are. It is low cost compared to some of these other interventions, whether it be surgical or did imaging or whatever. And it's ripe for change.
We've got a unique guest today. We talk to a lot of clinicians. Sometimes we talk to patients. We talk to leaders and advocates, people within the profession. Except today we're going to talk to someone who came to our profession from outside of our profession. Something a little bit different. Our guest today, I don't want to introduce her because I don't want to give too much away, because the first 15, 20 minutes of the episode, we go backwards through her career. And we learn about all the different superpowers she picked up along the way at all these different roles, and how she's using those superpowers now as the leader for one of the largest organizations in our profession. I mean, I guess I got to introduce her somehow, right? We're talking to the CEO of ATI, who also happens to sponsor the show. So thanks for doing that. ATI, for background, one of the leaders in clinical research within the PT profession. With more than 900 clinics across the nation, they place within the 100th percentile in CMS's merit-based incentive program for the second consecutive year. If you want to join their team and jumpstart your career, check out atipt.com. Now, this really was an interview about somebody who's a leader and came to PT in sort of a roundabout way. And I love people who come to PT in a roundabout way, because I came to PT in a roundabout way. But I like how she brings together all the different lessons that she learned in these seemingly non-connected careers, and what she's gonna do after she's just wrapping her first year as CEO at ATI, what she's gonna do in the future that will benefit all of us. So we'll get to that. Do want to say thanks to some more sponsors of the program. Physiotech is helping you add an additional $290 per patient per quarter for your PT clinic. How do they do that? Well, remote therapeutic monitoring can do that. Improve patient outcomes, reduce provider frustration, improve clinic revenue. Find out how to get started with RTM at physiotech.ca. That's physiotech.ca. And our friends at MW Therapy, delivering a modern all-in-one outpatient PT EMR with the built-in patient portal, marketing automation, and billing features you want at a great value. Find them online at mwtherapy.com, where switching your EMR is easy. Without further ado, you get to learn from our guest today. Enjoy. But I do want to welcome you, Sharon. Welcome to the podcast. That's it. We call it the Pintcast sometimes.
Great to be here. Thanks for having me.
All right, we're going to get to your background, because a lot of shows start off by just reading the resume of the guest, right? I want the audience to find out about you and your background a little bit differently, okay? So you have a variety of different types of jobs and roles, right? So what I want to do is I'm going to toss you, like batting practice, I'm going to toss you these things from your history, and I want you to try and figure out, it's like word association, what skills or views or superpowers you picked up from that job or that role that you still might use today. Because that's what we really are, right? We're a snowball going downhill. We pick up things, we use them, or we toss them. And I just think your background, this meandering thing, it was pretty unique. And I just wanted to see what you picked it up. So if you want, we'll start the show off by doing something like this. All right. Okay. So first off, you were a candy striper, which might seem like, well, it's this volunteer or internee type position. But I bet you what I know about candy strippers is they go so many different places and you get to see so many different things in a healthcare facility. So I wanted to know, what superpowers did you get out of being a candy striper?
So I was young. I was like 10, 12. I went with my Nana. And she was the volunteer, and then she brought me along. And I would say, one of my memories, because that was a long time ago.
Yeah.
A lot of it was in the cafeteria. We'd go and we'd go to, I thought eating in a cafeteria was awesome, but the way she interacted with people. And so I just came out with this, like, two pieces. One, just, I loved the environment.
Yeah.
In the hospital, taking care of people. And then two, all the people we would talk to in the cafeteria, she knew everyone. She's been doing this for a lot longer than I had. They were so, I don't know. I don't think they were just genuinely liked what they were doing. Yeah. And that like really connected with me. And they're all different. It could have been the priest, it could have been the surgeon, it could have been the pediatrician, it could have been any of the nurses, any of those folks.
Right.
And
yeah.
So, and to your point, like, we were, just like getting to know people, not with a title, but just like what made them, like coming to work every day and wanting to be a part of this hospital. That was pretty cool. So it was so intangible for me. Like, I don't even know what it was, but there was this feeling. There was like, I like it here. This is what I want to do.
Well, what I hear you saying is you were looking at because the cafeteria was not where the nurse belongs or where the doctor belonged or where the priest belonged. You were focusing on the person and what they brought to the situation or the conversation. So it was almost like that. It was like that common ground. It was the cafeteria where they were being they were being themselves.
Yeah. And they all were the purpose, right? They would all talk about something related to what they did at the hospital. And so that purpose, like having a purpose, like that just really resonated with me at a very young age.
We talked before we hit record, of course. The audience always hears me refer to that. I should just hit record whenever the guest gets on, because we wind up having great conversations before I hit record. And we, a lot of times people say, well, how can I be the best guest, or, how, give me some angle on how we can make this go right. And I always say, my job as a host is to make the guest feel comfortable enough that they forget we're being recorded. I don't want you to perform, right? And it almost feels like the cafeteria in this situation is that place. They were being, I don't know, maybe their true selves, because that wasn't where they were, I'm using air quotes on a podcast. It wasn't where they were on stage. It was, they were being.
I think a little bit too. So I said it was with my Nana. My Nana was probably, 70 years old or something. She'd been at this hospital for 20 plus years. They all knew my Nana. And so they would come over and chat. And so I think that was the other piece of it. They looked up to her. They were really comfortable with her. And so I got to learn through watching my Nana interact with these folks. And you're 100% right. She wasn't a patient. She was there serving the same purpose they were, just in a different way.
Yeah.
As a volunteer. So
How old were you then? Because these are pretty powerful things to see. When you said cafeteria, I immediately thought to the time I told my parents that I think I learned more in college in the hallways than I did in classroom. And they were like, well, then what did we send you there for? And I was like, well, no, you learn a lot in the hallways and the parties and the morning after, the parties. You really do. You grow. That's kind of the space to grow. And when you said cafeteria, I was like, how cool is that? Because that's an unexpected answer. And I knew something great was coming with it.
Yeah. I was thinking, I think she kind of snuck me in. I think you had to be a volunteer, like 12 to be a volunteer. But I think I started with, because she was, she took care of me. I think from 10 to like 16.
Wow, 10.
Yeah. And I liked it. I really enjoyed it a lot.
What else did you like about that? Because, as I mentioned before, when I think of candy strippers, you get to kind of go everywhere, really.
The other thing was I was very intrigued by just like the NICU and the imaging, and like I knew nothing about any of that. And so I was really like, I just liked learning, like walking around and looking at things. And so because I would deliver things, I would go up on the floors, those kinds of things, and deliver flowers or something like that. And so it was just like, I don't know. I mean, I it sounds really corny, and I'm not sure at the time, but it was like a big playground. I even though there's a lot of sick people, a lot of, things that are not so positive. I think the combination of helping people and then just all the people there were so committed. So,
What a great experience too, because you had this pretty adult experience, right? But you had that great safety net. There was a purpose. You weren't just
yeah,
following around. Like you were given sort of this purpose. So there was a reason for you to be there.
yeah. It was definitely, I mean, I can speak about it more articulately now than I did before, but I knew after that I wanted to be in healthcare, period. So by the time I was a junior in high school, I was like, I don't know if I want to be a provider. I don't know if I want to be, and I had an uncle who was an ENT, and it was just about the time where the healthcare landscape was changing just a little bit, with Medicare and things like that. And so he said, well, you can be a provider. He said, but you know who has all the power? He said, the administrators. And I said, what do you mean? He goes, I touch 10 patients a day or 20 patients a day. He said, the administrators make the decisions that allow us to touch a whole community. I don't know. I mean, again, he was just, and he was actually kind of, angry about it or whatever. He was like, the docs used to have all the power and now they don't. It's the administrators. But the way he said it to me actually resonated, because I was like, wow, it'd be really nice to have an influence over a whole community or a population or across the country. And so that was sort of the why in the road. I went pre-med, I did all of that because I still wasn't sure. And then the why in the road after I talked to Uncle Vin was, maybe I should think about being an administrator.
Yeah.
So that was how that decision was made.
I focus a lot on questions, and you sort of took exactly what I was thinking, which is the how came later. But he was highlighting, listen, I can see what you might be intrigued by. I know who you are. So you've got who, what, and then your why was, listen, here's this underlying purpose or what I want to do. And then how do I actually do that? You could do it a multitude of ways.
Right.
And however you do it, it really needs to impress you. A lot of times we do things because we want them to impress or satisfy others. But when you find that thing that satisfies you, that's a powerful thing. How.
Yeah. No, you got to be true to yourself.
Okay. So let's keep going. That was just number one. That was one talk. I thought that would go faster, but we went deep with Candy Striper. You worked with Ernst & Young? I don't know a lot about them other than, and I purposefully didn't do a ton of research, but it's really like consulting and thought and charting courses. That's sort of what I get at Ernst & Young. What superpowers or what skills did you get about your time from your time there?
So my goal there, so I'm a little bit of a healthcare geek, to be honest. And so
that's cool.
I was like, okay, well, if I do consulting, I can travel around the country and see how healthcare is delivered in different parts of the country, in different hospitals, different health systems. And so I was like, I'm in. And what young person doesn't like to travel? So
sure.
I thought this would be really interesting. And, I've been fortunate to have some good mentors throughout my life. And so one of my mentors said to me, he said, this is going to be a really good opportunity for you. And so I would say when you're a consultant, you get a lot of exposure to different environments, different levels of thinking, all of that. I'd say number two, as a consultant, you'd be very methodical in how you approach things around problem solving and or going from an idea to a implemented whatever action. So those would be two of the things. And I'd say third is I just have developed a tremendous network because I worked in so many different types of settings. Ernst & Young at the time was one of the big 6 firms. I don't think there's not that many anymore.
Right.
And so it was a fantastic opportunity to do what I wanted to do, which was get exposure to healthcare on a national level. But then also what I didn't realize was it was a very disciplined kind of way of problem solving and implementing change.
Yeah, I geek about innovation. That's like been the thing. It's almost a buzzword for the last couple of years. But for me, it's really fascinating. And when I hear people who study it, they talk about a lot of things that you just said, which is some people might think of problem solving or innovation as this magic trick or this thing that just happened. It was a stroke of insight. It just happened. And can you processize problem solving? I don't think anybody disagrees with that, right? So
Yeah.
your skill set or what you brought to the table was you had a bank, or the organization had a bank of problems they had solved and ways they had solved it. And you got to sort of peek under the hood at so many different organizations who had different problems. But I bet you saw a lot of patterns there, right? Like in terms of, hey, we've seen this before, we can kind of customize their solution, but we get the gist.
Yeah. I would say one of the things that there were we did a lot of different projects with a lot of different organizations and different ways to get there. I would say one of the things actually that resonated with me as I got into other organizations was the common thread of you can have great healthcare, you can do a great job delivering, but people need to have access.
Yeah.
And so that was one. So that was something I didn't walk in with that. But as I got exposed, it became a little bit of a personal area of interest.
Was that something you spotted, or was it something other people kept highlighting too?
No, it was as I went to these different organizations, I would see the same theme play out. And so some of the things, and the good fortune, again, I was fortunate enough to do some be on some projects at different organizations, and some of them were focused on access. But to be able to see it at different organizations and to have a little bit of a focus on that, it became my pet area of healthcare that I was hyper focused on. Everywhere I went, I would notice it, even if it wasn't part of the project.
It's funny because when you start doing that, it's like, somebody told me I bought a Jeep a couple of years ago, and someone says the minute you buy a Jeep, all you notice is Jeeps on the road.
It's the same thing. Yeah.
There were the same amount of Jeeps yesterday than there were the day after I bought it, but you just keep seeing it. Now you see it everywhere. Yep. Yeah.
So that afforded me, like I said, some new skills and abilities, but it also allowed me to kind of do my little study around different organizations and in healthcare delivery and what they did for access. And everyone had their strengths, but there were always gaps too.
Right.
And then when you talk about innovation, I mean, that's that again. When we think about delivering healthcare, improving the lives of our communities, and then also thinking about just as a society, how do we improve our healthcare model and how people access it? Like that is one of the biggest keys. You can have great healthcare, great research and teaching, but people have to be able to get it. Yeah.
We're going to get into specifically PT access and another access innovation that I think is pretty cool. And when I found out about your background, I was like, oh, I've got to ask her about this, but I don't want to skip one.
All right.
You worked at Brigham and Women's Hospital, VP of Ambulatory and Women's Health. So just like briefly describe the role, and then what superpower, what things did you pick up from your time there?
The role was a traditional hospital administrator overseeing women's health, ambulatory. The biggest thing there was, research, teaching, fantastic, focused on patient care, just a fantastic organization. And did a lot of big capital projects. Those are, capital projects are big, new NICU, new ambulatory facility, et cetera. I think the biggest thing was, this is where I kind of put access and then my second passion, which is ambulatory care. And so that was the first time they had a role in ambulatory care. And this was back in the 2000s, mid 2000s. And no one ever thought, especially in an academic organization, that ambulatory care would be important. It was like a means to an end, right? And so that was very interesting for me. And I learned a lot. I had to do a lot of research and sort of strategy work to help people understand why ambulatory care was so important. And there were other folks that were doing saying how ambulatory care was going to become, we do more outpatient surgeries, people would recover at home. We would, all these things that are current now.
Right.
And super important for, our healthcare delivery system, but no one believed it back then. So that was really interesting to me. It was sort of like a little startup within an academic organization, but more importantly, I did some firsts in ambulatory at the Brigham.
Like what?
With the Brigham. So we did an ambulatory care building out like 30 miles away from the hospital. And we made it a ambulatory community. So we had everything from primary care to imaging labs, ORs for AM surge. And then we did the first urgent care for the system. And when you create that kind of an ecosystem, it's amazing when you think about the patient experience one-stop shopping, making it as easy as possible for patients. That's what we did. And it was magical. And more importantly, we do a lot of that now. But back in the day, that was a little bit of a new thing.
Yeah.
And so it was great. And again, so my two passions, access and ambulatory.
I was just going to say, I always like, a lot of the times the themes before we hit the record button aren't necessarily there. I don't know where this is going to go as a host. My job is to sort of pay attention. And there it is again. I mean, you just highlighted it. There's that, hey, we do great stuff, but if there's no access to it, it doesn't matter. So how do we design it to bake access into the cake from the beginning? It sounds like you saw that and did that.
It was perceived as threatening and negative to the hospitals. Oh yeah. But the concept was you bringing care to where people live so that they don't have to drive into downtown Boston and pay big parking fees and get stressed about driving in the city.
Well, who's it for, right? I mean, we built a hospital, we put everything in the hospital, and that makes it really, that lowers the bar, makes it easier for the people who work in the hospital, makes it harder for the people who the healthcare is designed for. I mean, growing up when I was younger, we always heard, well, doctors used to make house calls. And that was, back in the 20s, 30s, 40s. And then all of a sudden it was like, well, we have more specialized equipment. So we have to have it at this one place because it's not portable. So they centralized it. And it sounds like you were instrumental in saying, hey, what if we push this pendulum back the other way towards the people?
Yeah. And I think the bifurcation, I mean, tertiary care does require, a specialized environment, but when we're thinking about, ambulatory care, and we're thinking about things that are just, that are a little more commonplace, primary care, day surgeries, those kinds of things, why not have them in the community? And that's a theme that we'll continue to talk about, I'm sure, whether it be my next role at MinuteClinic or even what we're doing at ATI.
I mean, we have to go. So like the fact that we've already talked about access several times, and now I get to ask you about this because the audience, I love when they don't. This is why I didn't want to give them your resume first. I mean, I don't want to say invented. Did you invent, or what was your role with I'm just going to say this: CVS MinuteClinic. What?
Yeah. So CVS MinuteClinic, I was there for about 8 years, and no, I didn't invent it. A bunch of physicians did about 20 years ago, believe it or not.
Wow.
Very forward thinking. But I loved the disruptive nature. If you think about it, and you're young, and probably a lot of people are young, but back in the day, you either go to the emergency room or you go to your PCP. There was nothing in the middle. And so so when you think about access, right, and you think about I was just so impressed with that concept of doing something that was disruptive and provided options for patients. And by the way, when in MinuteClinic, 50% of the patients were seen after traditional physician hours.
Really?
So evenings and weekends. You think about working people. You think about people that have, kids that are in school, et cetera, et cetera. So I loved the disruptive nature and the creating access. Retail health is all about making it easy for patients, making it convenient for patients, and pushing the envelope on whatever you can do so that the provider can just see the patient.
That's why they signed up, right? I mean, that was the idea where they signed up. But if there's a barrier, so now we go back to, obviously, I mean, putting first of all, the marketing on that, just calling it a MinuteClinic, because one of the things people think of is, I'm going to show up, I'm going to have to wait around for a while, it's going to take long, I don't have time, and you put it right in the name. It's a MinuteClinic.
Yeah. That was the concept, but of course people would be like, I had to wait 20 minutes. I thought it was a MinuteClinic. So it definitely was challenging at times. It worked both ways. But, I think that, so MinuteClinic, we were across almost all the states, and we were located in CVS stores. Well, guess what? Where are CVS stores located? They're located where people live. People
right?
Shop. And by the way, they're located where not a lot of people live sometimes, depending. And so it was a brilliant concept. I can take no credit for it. But it was creating access that was easy, convenient, affordable, and high quality care.
Well, I got to ask this. So when you said disruptive, right? If my boss in radio told me, if you're not getting called into my office, this is the general manager. I was running a rock station. He said, if you're not getting called into my office to get in trouble, once a month, You're not living on the edge enough, right?
Yeah.
So with you saying disruption, some people had to be angry, scared, worried, something. Who were those types of people, and what were they angry about?
Oh, there were plenty, trust me. We had a very talented team that worked at Minute Clinic at CVS Health, thinking about this and thinking about how to weave this into the traditional healthcare fabric. Troy Brennan was the CMO, and he's a legacy, but he really thought about how do you integrate Minute Clinic so that people don't think that it's duplicative care, that it's not connected care, et cetera, et cetera. But so some of those things allowed physicians. So I'd say there was a half of the hospitals and health system, traditional healthcare providers saw Minute Clinic as a partner and a way to extend their practice. But the other half didn't. They saw it as competition. They saw it as not high quality care. It was they weren't informed necessarily, but nonetheless, that was their perception. And so I think with any new innovation, right, that's disruptive, you've got to bring people along. And there's a cycle there. It takes a little bit of time, and you've got to do the right thing. So you got to make sure that your patients are happy, because patients, act with their feet. You've got to make sure that the quality of care is there, and whoever would credential you does that. And you've got to make sure that you are that there is continuity to care. And this is what I love about this role is this is very similar to what I'm doing at ATI.
Right. Well, that's where this is going to go, right? So we've seen accessibility, we've seen access, but you pointed out something else as well. It's got to be quality, right? Yep. So it's make the good thing, but then if people can't access it, doesn't matter. But if you can access it and it's not good, that's a fail too. So let's go to your role.
And let's just add the third. It has to be affordable.
Correct. That could be an access issue too, right? I mean, because if I can't afford it, it might be great, but now it's on a mountaintop somewhere. All right. So let's fast forward to your next role for the speed round. You're at ATI. You get to lead physical therapists across the country, more than 900 locations. What superpower have you picked up? And then I'll ask you to reverse it now too, which is which superpowers from your past that we just talked about do you get to employ now at ATI?
So I would say walking into the therapies, right, in the musculoskeletal space, I was interested. I see it as an area that has tremendous potential. And so as I got here, it became much, much clearer. So we think about, again, we think about the triple aim. You want to provide high quality care that's accessible and affordable. And so when you think about the therapies, PT and the other therapies, I'll lump them all together. They are they help multiple populations, whether it be post-recovery, strengthening, the athlete that wants to do better, whatever it is, right? It's the healthy and folks that are also have some kind of injury or ailment. Number two, it's really not, it's super empowering. It's both physical and mental in regards to helping people really, get back to their goals, whatever those are. It is low cost compared to some of these other interventions, whether it be surgical or did imaging or whatever. And it's ripe for change. So that's what I didn't realize. I knew that it was an area that could be improved upon and disrupted, but it's this little gem that just needs to be shined. Like, it has such a place in our musculoskeletal ecosystem. And yet the average person, and we as a society have not valued this at the level that it should be.
All right.
And so that's what I learned in my 1 year here at ATI, there's even more potential here than I thought.
Okay. So we've got potential. Let's stay with the theme of access now.
Yeah.
What are we as a profession? First of all, I got to say, as you were saying all that, Mike, it's really cool to hear someone who has a healthcare background but is not a physical therapist list all of the strengths and values that I think therapists or the profession like to say we have inside, right? So you spotted those. So it sounds like, because that's what Oprah says, right? People want to be seen and heard and understood. So far, it sounds like Sharon gets us. She gets us. So let's go back to access. How do we do those things? What are we doing wrong? So now you get to be a consultant too, which is what have we been doing wrong that hasn't met that access, right? Because we have that quality. It is affordable. So it feels like the only on your triple aim that the only thing we're missing is the access. What have we been doing wrong? How do we do better?
So there's two ways I think about that. So one is with my ATI hat on, right? So how do we think about making ATI, physical therapy in all of our therapies accessible to people? And so one, they have to be affordable, right? That is a deterrent for people. And so offering multiple, insurance coverage, government, commercial, all that kind of stuff, and transparency around that. Number two is, folks, I think it's 10 miles. I may be getting that mixed up, but they don't want to travel too far for this care because it's frequent, right? And
right, correct.
It takes a little bit of time. So how do you locate and make sure you have a broad enough footprint so that people can come in and do it at their convenience? So they're not, because that is also a hurdle. Like if you have to drive too far, they're not going there. And then I would say the making sure that you are reaching out to communities that either don't know a lot about PT care, don't have a lot of access, they're underserved, right? They just don't have, a lot of access points. And then working with their primary care and other folks like that, really so that you kind of surround people and help them understand why this is important, and then how they can, is it transportation? Is it co-pays, whatever it is that are their hurdles. And then I'd say the last one, just from an ATI perspective, is meeting patients where they are. And so I believe strongly in the hybrid model. So we have bricks and mortar, hands-on care, and then there's also an opportunity to work with patients virtually. And that doesn't work for everyone. And I don't think it's an all or none. I think it's how do we think about meshing those two together? So that's the ATI. But I think from a PT therapist perspective, when we think about access for it, I feel like, and I've only been doing this for a year, but compared to other areas of healthcare that I've been in,
right,
it's fragmented.
Okay,
I think it's good that we have health systems that provide PT. There are larger organizations like ATI and others. And then there's a lot of onesie, twosie, family owned. I think that's great, but we haven't come together with one strong voice. And we have different professional organizations that are doing that or trying to do that. But I think if we could get our message out there, help people understand what PT is. I talk to patients all the time in clinics, and I know others, my doctor told me I had to do this. I don't really know what it is. I was a little intimidated about coming here. I didn't really know. I came because he or she told me I had to come, right? So I just don't think people understand the value of PT. And then I think the second thing is we need to be focused on what are the hurdles, right? For people getting there. Some of it's knowledge, some of it's, worried about out-of-pocket expenditures. Some of it is, the certain populations, Medicaid population or populations in communities that just aren't familiar with what PT is, helping them there. But so I think we as a profession have an opportunity to come together and have a stronger voice. And we talk about PT first, we don't need to go to PT once we're hurt. There are lots of different ways that PT can take an important part in a person's lives. And so I just think we as a society haven't embraced this. And I think we as a profession need to have a stronger voice.
You keep saying words like voice and access, obviously access being a theme so far of just what we've been talking about today. And then because to me, I love playing on words. Access can mean a couple different things. Physical access, financial can be an access. Not understanding that there's a solution. That's an access issue. Yeah. So Sharon will have my resume on her desk tomorrow morning, because communicating that value is so important, and it's really nuanced, right? Because I think I see a lot of messaging from organizations within our profession, and they talk about physical therapy first. And I'm not going to knock any of them because I think they're rooted in value. But I think importantly, if we put the value, if we can show, to use the mattress model, which is don't sell the mattress, sell me a good night's sleep. A lot of times PT, we love to sell PT or the doctorate or our evidence-based practice. None of those things are bad, in my opinion.
Yeah.
But from a person hearing that, an audience perspective, I want to understand all those things you just mentioned. Some of our strength is our profession so wide. Some of the weaknesses, we're so wide, there's no one size fits all message for all the different people we can help. So I think messaging and using that voice to come together and have a collective voice only strengthens us to show value from a patient perspective.
Yeah. And you think about it, so there's different, just to your point, like when you think about words. So when I think about patients, the most important thing to them is, we talk about patient reported outcomes. It's like, what are their goals in life? And then how do we help them, not in life, but with their current situation,
Right.
How do we help them accomplish those? Does a therapy or therapist help you accomplish that? So that's one way to think about it. And then I think just you could juxtaposition that with all the research out there that just shows that this this therapy care can be, one, restorative, two, preventative, three, it can certainly keep you from going down some roads that you probably don't want to go down. And so we think about getting the message out there. There's a patient perspective. And then I think, being in healthcare, you've got to think about the science, right? There is enough literature and research out there that proves that this is at least a good starting point for patients that have some kind of a need in the musculoskeletal space. And so again, we as a society, whether it be in healthcare, whether in healthcare in particular, we need to do better here. And then we as a profession need to figure out how to put these pieces together to make it easy for people to understand why PT and all of our therapies need to be valued.
Deserve to be paid attention to it and to be utilized. All right. So we've caught up on your career, right? We just went reverse through the resume, right? So let's get really specific where you are now, because now we've caught up to present. We've done past, present, and now let's do future. How is ATI specifically doing some of those things? Because similar to a role like a CVS, where you had physical space where it needed to be, right, in people's communities, ATI 900 plus locations. How is ATI going to tackle some of the issues we just talked about? What are the things we look forward to in the future?
So I mentioned one of them that I'm excited that we've been working on for a little bit, which is the hybrid model.
Yeah.
And I think that is, we have it in different parts of the country. We have a national practice. We can provide virtual care and the bricks and mortar care. And so I think, I'm a big proponent of that. I think it helps with not only access, it also helps with adherence, and it also helps empower patients, right?
Sure.
To take this on their own and do their exercises and all that kind of stuff. So I think that's a big one. I would say, another is we're going to continue. We always look at the patient journey and what are the obstacles getting in the way for patients to access the care. And so we are constantly challenging ourselves and looking at how we, our hours of operation, how we show up for our patients. We have a team-based care model. And so we also think about that as having multiple providers, if you will, that they interact with and they can learn differently from. I would say we're very committed to making sure that care is affordable. And so, again, working with multiple commercial and government payers and looking at how to make sure that patients understand what their responsibility is and being really transparent around that. I think that's super important for patients so that they know what they're walking into, especially with multiple visits and an ongoing relationship.
Well, it sounds like you're paying attention to the people you're trying to serve, paying attention to what reasons or what obstacles are in their way and attempting to remove those. Again, that's access.
Yeah. I'd say, another thing that we had at MinuteClinic and we have here, we're a national practice and we have standard clinical guidelines. And of course, there's always decision-making and autonomy by a provider to provide the best care based on what the patient's needs are. But I think knowing anytime you go into an ATI, it's the same clinical standards, it's the same guidelines, and even just the same registration process. right? So we have one way of doing things across all of our 900 plus clinics. And so again, that was a page I took out of the Minute Clinic book, but to consumers, to patients, like knowing that consistency is there,
Right.
I think is really, it just, again, removes one more hurdle for a patient. And then that the clinical guidelines and the rigor behind the clinical, the way we provide care, all outcomes based, et cetera, based on, good best practices and research, is applied across all of the ATIs.
That's what you want to bake in the cake. That's
Yeah.
what you want to make sure is included in the ingredients, right?
Yeah.
Yeah.
And I think that is a differentiator for us. And I learned it at Minute Clinic, like I said, whether it be patients traveling, like, around to different places, or just like that brand and understanding what that brand stands for is, believe it or not, and it makes access easier.
Well, that's what a brand is. I mean, that's what we come back to, like, my communications background. People think it's a logo or colors. And I said, that's a really visible part of a brand. A brand's a feeling. What do I get when I walk in, or when I think of you, or, what experience is it? Is it annoying to book a time? That's a negative brand experience. Is the place, hard to get to? Negative brand experience. So it's a lot more than the logo and the colors.
Yeah. I'd say the other thing that I'm really pleased with at ATI is, I'm under the mantra of happy providers, happy patients. And so how do we support our teams and create the culture that makes people, feel good about what they're doing every day? It makes them feel like I felt when I was a candy striper,
Right.
just like I liked being there. This was my place. And so we work hard on that. It's not static, and it's not perfect. But the providers they're who we are, right? They're in a care delivery organization. And so making sure the providers have the tools they need, the support they need, and or feel good about coming to the clinic every day, or coming to the work site, wherever they are, I think is really important. And again, our patients feel that. Our patients feel cared for when they go into the clinic, and it's how they're greeted. It's what their treatment plan is. And then it's how the provider and the team there bends over backwards to help them when they had to bring in their granddaughter because, she didn't have a babysitter and they didn't want to miss their session. So I'd say that. So creating a welcoming environment, creating a spirit and an energy in our clinics. It again, when you talk about access, it's inviting, and it makes people want to be there, our patients, even though they don't want to be there.
But that's part of brand, right? I mean, there was a pretty controversial book that came out, and I think it was like Patients Come Second. And everybody was like, you can't do that. And the idea there is, if you put your providers first, if you really take care of them, they'll take care of your patients. So it really is looking at things from an up or downstream perspective. Of course, we're showing up to create a healthcare service as our brand, but you get better results when you can take care of those providers. Their reason for showing up are the patients.
Yep.
Sharon, are you ready to play a little game we call 3 questions?
Of course.
Let's do 3 questions. All right, 3 random questions. I pulled them out of this deck of questions.
All right.
You ready for this? All right. First question is, if you could make one of your hobbies into a profession, what would it be? We're trying to get inside the mind of Sharon. If you could make one of your hobbies a profession, what would it be?
I think it is a profession. I just could never do it.
What is it?
So I love stand-up paddleboarding.
Yeah.
It's one of my favorite things. I think it is a profession. Like, there are professional paddleboarders.
Maybe.
I just could never do that because I'm not good enough. But
where do you do? Are you like a lake? Is this an ocean thing? What are you doing?
So I would put together. So hey, I put together active. I like being active, outdoors, and I love the water. So that's how that comes together.
Or, hey, listen, I'm not going to tell you what to do at ATI, but like, any of your clinics near bodies of water, that could be a great way to do balance training.
It could be.
Just throwing it out there.
There we go. Thank you.
Second question. Did you have, we might've touched on this a little bit, but did you have a favorite teacher or a teacher who made a really big impact on your life? Is there someone that comes to mind when that question gets thrown out?
Yeah, and actually, I don't think it's one person. It's many of the mentors. One of the things. I mean, let's state the obvious. I'm a female, and I've been doing this for a little while, and it's not always easy for women to break into different professions and then to continue to progress up into senior management. In PT at ATI, 66% of the ATIs are women. But we only have about 25% of the women are in leadership positions. And that's not specific to ATI.
Sure.
And so I would say the one person that helped me with all of this, healthcare, my career, and being a female leader that wants to make a difference, was Kate Walsh. Kate Walsh she just retired as the CEO at Boston Medical Center. She showed me how to do all of those, or helped me. She role modeled it and then guided me on how to be successful in all of those areas. Being a good leader, being in healthcare and being impactful and living out a purpose. And then also being a female that, sometimes has to overcome different hurdles than other genders, and just continuing to pave the way for others.
Love hearing that. All right. Third question on 3 questions. If you were going on a road trip, what are 3 must-haves that you couldn't leave on the road trip without? I mean, you do a lot of traveling, I'm guessing, with ATI. I mean, locations all over the place and where you're located and where you live. Road trip, 3 things can't leave without. What are they?
Music.
Gotta have it.
Good music. People. Even if they don't come with me, that I am engaging with them and able to, to learn and to talk. And then I would say good snacks.
Gotta have snacks for a road trip.
I do. I like good snacks.
What's a must-have munchie? What's going to be in the snack bag?
Well, I kind of boring snacks because they're easy to pack, but I love mixed nuts.
And they keep pretty well.
Yeah, they're easy to eat. Good high, protein, and then my some water.
Yeah. All right. There's your road trip. That's 3 questions. Last thing we do on the show, Sharon, is called the parting shot. Parting shot brought to you by our friends from the Academy of Orthopedic PT. Wherever you want to level up your orthopedic career, find them online at orthopt.org. Their current concepts of orthopedic PT. You want to take that OCS exam, that is the resource for you. So this is your chance. Parting shot, last thing people are going to remember. They always remember the last thing, right? So time for a soapbox statement or a mic drop moment, whatever you'd want to leave the audience with. Sharon, what's your parting shot?
So I think probably twofold. One is, the therapies and PT and the whole musculoskeletal space, we have an opportunity to have even a greater impact than we're having now across the healthcare landscape. And we have to join forces and come together and do that. And I think people are certainly trying, but I'm excited about that. And then number 2 is just ATI is an awesome organization, whether you want to receive care there, whether you want to join the team, or you want to, we want to be leaders and helpful in the first part, which is really elevating and moving the whole perception and value of physical therapy and all the therapies in our healthcare ecosystem.
Well, Sharon, thanks for coming to our profession, because I think your background, as we heard of all of your superpowers that you picked up along the way in your journey so far, I mean, that's what we need. We need things from outside that have worked, that understand people, to bring them to this profession, to help us unlock and get access so we could help more people. So thanks for coming here, because, we need innovators and leaders like you.
Thanks for having me. It was a lot of fun.
All right. Well, let's say the best conversations happen at happy hour. Thanks for coming to ours.
Like what you hear? Tell a friend or leave a review on iTunes or Google Play.
The show today is brought to you by the Brooks Institute of Higher Learning, an innovator in providing advanced, post-professional education. The Brooks IHL offers 7 on-site PT residencies, including orthopedics, women's health, geriatrics, pediatrics, sports, and neurology, as well as a neurologic OT fellowship, a competitive OMPT fellowship, and a speech therapy clinical fellowship. Therapists that complete a residency or fellowship through the Brooks IHL will markedly advance their knowledge and skills in a specialty area of practice. Learn more about how a residency or fellowship can help you advance your professional development at brooksihl.org.
Our home on the internet. PTPintcast.com. Created by Build PT. Build PT provides marketing services specifically for private practice PTs. From website development and hosting, providing content marketing solutions for PT clinics across the country. See what Build PT can do for you today at buildpt.com.
The PT Pintcast is a product of PT Pintcast LLC. It is hosted and produced by PT Pintcast CEO Jim McKay and CBO Sky Donovan from Marymount University. We talk PT, drink beer, and record it. This has been another pour from the PT Pintcast. The PT Pintcast is intended for educational purposes only. No clinical decision making should be based solely on one source. While care is taken to ensure accuracy, factual errors can be present. More on the show at ptpintcast.com.